Hi everyone, this is Patricia from the International Hospital Federation. I hope you're all safe and well, and thank you very much for joining us today. Managing COVID-19 has been extremely challenging for hospitals and health systems around the globe. The IHF is hosting this webinar and live Q&A series to share experiences, good practices, insights, and lessons learned from our members and other organizations. This series has been created with healthcare providers for healthcare providers, including executives and decision makers, and all who are involved in preparing for and managing COVID-19. I would now like to introduce the moderator of this webinar, IHF CEO, Eric de Rudenbeck. Eric?
Yes, thank you very much, Patricia. Welcome, everyone. Good morning, good afternoon, good evening. In this webinar, we'll have the great opportunity to hear Professor Lee from Singapore that is going to share the overall experience and response to the pandemic from the perspective of the country and the perspective of the Changi General Hospital experience that he is leading, and how they've managed, to sustain staff welfare and morale, which is a very important topic that we all are facing more and more with this epidemic that is putting a lot of strain on the health workforce. Like in Korea, that we had the chance to have the previous webinar, obviously the previous experience of epidemics in Singapore has allowed to be better prepared than many other countries. But like with this new coronavirus, it looks that the flexibility to the response was also highly necessary, and we'll also probably have a chance to discuss of what is presented, in the media, like some kind of a rebound of COVID in Singapore, how they have dealt with that. I also believe that's going to be of interest for a lot of us from around the world, where we still have under lockdown and are quite concerned about moving back to business and reopening everything. So also I really want to underscore that, like any other IHF hosted webinar, the presentation will be offering the perspective from leadership and management for health service providers. So please ask your questions as much as possible in this direction, because we will not be covering the purely clinical issues. And I will do my best to take over your questions. Don't forget that you can also support existing questions, that if you have the same concern, rather than to re-ask the same ones. Let me then introduce you. It's really a great pleasure. We have been working for many years and knowing each other for many years. Professor Chien Lee, he's the Chief Executive Officer for Changi General Hospital in Singapore. Professor Lee is a public health physician by training, and in addition of being the Chief Executive Officer of a 1,000 university hospital bed, recognized one of the best university hospitals of the world, and I can say that because it's coming from the IHF. And he is also currently the Deputy Group Chief Executive of the Regional Health System, because as you will see, Singapore is divided in a number of clusters of hospitals for the Singhealth Authority. Prior to this appointment, he had leadership position in the Ministry of Health Singapore, where he was involved in the strategic development and improvement of health services, as well as health regulation and finance. So a very broad experience at the level of policy and at the level of leading a health service facility of very large importance. He's also a faculty person, because he holds an appointment as adjunct professor in the South Swee Hock School of Public Health, that is part of National University of Singapore, Duke-NUS Medical School, and Singapore University of Technology and Design. So very broad knowledge and experience, and we are really eager to listen to you, Professor Lee. The floor is yours.
Thank you very much, Eric, for the kind introduction, and good evening from Singapore to everyone who is listening in. I will go straight into my presentation with regards to how we respond to COVID-19 in Singapore. And just starting first with the situation update in Singapore. As you can see, if you want the latest figures of what's happening in Singapore, we have the Ministry of Health Singapore has a website which gives an overview of the current situation and a summary table of all the cases, as well as a summary of the number of cases and the case status. Currently in Singapore, we have around 10,000 cases, and in our intensive care unit, we have 25 cases and around 12 deaths to date. If you look at the epidemic curve on the left, you will see that from the bottom, in terms of the imported cases with our entry restrictions, we have not got an imported case for a few days already. And in terms of the local cases, in terms of the local community cases, it is also coming down, the yellow bar, which shows the community. But the steep rise in the case is mainly in terms of our migrant workers who are staying in the dormitory. So that is, in a rough nutshell, the situation in Singapore. And the way in which Singapore has tried to address this COVID-19 was to take a coordinated whole of government approach. And this was actually set up on the 22nd of January. And interestingly, our first case came in on the 23rd of January, because we got the alert of something was happening in China. And from our previous experience with SARS, we decided it's good to be proactive and try our best to tackle it upfront. And it's co-chaired by two ministers from Health and National Development. And it had representation from across the sectors. And it was to direct the whole effort nationally, as well as to come up with measures that are calibrated based on the risk assessment of Singapore's situation. Because we recognize that this is a novel virus, which we do not know much about it, but so we need to be agile and nimble and respond as the situation, as our knowledge and the science of the disease evolves. So this chart shows in a nutshell the activities of the various ministries. So you will find that starting from the top right-hand corner at 1 o'clock is our National Environmental Agency and the town councils, which works on the cleaning of the places. Our Singapore Police Force assisted in the investigation, for example, in doing contact tracing. Our ICA, which is our charge of our immigration and border control, is looking at that area. And we also have the community support, as well as our schools and our scientists are also working on it, and also the employers. And for the healthcare family, these are the whole series of things that we are working on, from ensuring adequacy of services to adequacy of supplies, as well as being up to date on the latest developments with regards to the disease. So it is a whole of a country approach. And our strategy has been, I think, as in many countries, to flatten the curve and keep the infection rate as low as possible, so that the healthcare system is not overwhelmed. And we took a three-pronged approach. One is to reduce the importation, which is the enhanced border control. Two is the early detection and isolation of cases. I will elaborate more on this. And then third is the emphasis on the social responsibility and good personal hygiene. In terms of the early detection and isolation, our priority from the start has been to detect all possible cases early, contact trace them, and to contain the further spread. So we tested suspected cases for COVID-19, and we used the WHO's definition as a starting point, modified for the Singapore context. And in order to do that, we had to ramp up our lab testing capabilities. We also enhanced the surveillance across various settings in the community and the primary care. So in the community, what we had were primary care clinics, which were privately run, but learning from our experience, this was our experience with the H1N1 outbreak, which happened a few years ago, where we recognized that we should not be relying only on the hospitals to manage this, but we needed also to involve the primary care providers. So we have around nearly 1,000 primary care clinics that were designated as primary health preparedness clinics. And they are clinics which have been provided the necessary personal protective equipment and the relevant protocols, and our polyclinics, which are the government-owned mega clinics, where they could then conduct swaps. And what we did was we have this what we call SASH, a swap and send home, where if someone is symptomatic and fits the suspect case definition, we will swap them and then we send them home with a medical leave for 5 days, and the results will be sent to the labs. And if it is positive, they'll be called and sent to the hospital. But if it's negative, they continue to stay at home to serve out their medical leave. So the cases that we swap will include those that fit the case definition, cases with a prolonged acute respiratory illness, cases of community-acquired pneumonia, as well as some sentinel respiratory tract infection surveillance. And in the hospitals, we tested all patients that came in with pneumonia. So, and we did pick up quite several cases based on this kind of a surveillance program. As of earlier this month, the government introduced what we call a circuit breaker, which is the aim to slow the spread of the virus through enhanced safe distancing measures. And this included closing most schools and moving them to full home-based learning, but keeping the essential services open. So in terms of the restaurants and the food centers, you could take away, you could also ask for delivery, but you can't eat there. And but our supermarkets and the essential food areas are open, so you can still go to the supermarkets. And our parks at that time was you can exercise outside your home, but it's within the community. And we also required the wearing of masks. And we also introduced strict penalties for non-compliance. For example, we have what we call stay-home notice. So for example, someone who has come back from a country which we considered having a disease outbreak there, when they reach back to Singapore, you put them on what we call a 14-day stay-home notice, and they're supposed to stay home for those periods. But if they don't stay home, they breach the orders, then they could be severe penalties. And we also encourage employers to allow their staff to work from home. And also we have, and I think the key thing here is, but each of these, when it was implemented, there were concurrent measures to ensure that the technology as well as the support system were there. So for example, when we say that the work had to stop, we ensured that those employees would, in certain key areas, would still continue to be paid, so that the hardship, and the government also introduced support budgets. And the other important thing, I think, especially in any outbreak, is the public communications, because understandably the public is concerned. So this is a picture of our Prime Minister. He has open communication with residents. We have regular press conferences to update the public, where our minister, the two co-chairs of the ministerial task force, as well as our director for medical services, our chief medical officer is there. We also have an app, WhatsApp app, where you can subscribe to it, and it will send you regular updates on what's happening. So every day we get updates on how many cases there are, what are the new regulations, what are the new measures. So that's how we keep updated. And if you want to know more, there's a QR code there, and this QR code, I tested it, it works. You can actually go in and find more information, or you can go direct to the Ministry of Health website. So that is what is happening at the national level. So now coming to my hospital. My hospital is a 1,000-bed acute teaching hospital, and we are, in a sense, a regional hospital at the same time, where we manage up the needs of the patients, of the residents in the eastern part of Singapore. And for us, we our admissions, around 80 to 85% of our admissions are through our emergency department, and with around 10 to 15% are elective cases. So our first case was detected on the 26th of January, which is around 3 days after the first case in Singapore. And to date, as of yesterday, we have around 347. As you can see, the initial period was quite quiet until the 18th of March, which is just around 1 month ago, where the numbers started going up exponentially. And this again was because of the influx of the migrant workers for the dormitory. Yeah, because for us, we treat everyone in the same way, regardless of where you come from. So we will just manage them accordingly. One of the key things that we had put in place following the SARS, so I will be drawing some experiences that we had from SARS and how we adapted it, was to set up a ops center. So this ops center has always been there, but with this crisis, we beefed it up. And I've included the faces of the people running it, because at the end of the day, this battle is to be won by people, and it is not just the systems and the processes. So the importance of the ops center is that it is the single source of truth for what is happening in the hospital, because in any crisis, there will be various different information coming out, and people are unsure, is this the latest or is it not the latest? So there are the source of truth. So even for me as a CEO of the hospital, if I issue a directive, it comes through our ops center. It doesn't come directly from me. When it comes from me, it could be seeking for views, seeking for opinions. But if it is something that is to be implemented, it comes through what you see at the right bottom corner, what we call our ops instructions, which we issue every day. And that includes the protocols, what are the new items, and what are the areas that you need to look into. And as part of our ops center is also our contact tracing team, which as soon as a patient is confirmed to be positive, we will come up with what we call an activity map within 2 hours to find out where did the patient go 14 days before their symptoms started, to see where they could have possibly got infected, as well as the period after the symptoms developed until when they were admitted to hospital, to see who they could possibly have affected. And as you can see from this post, they were still working at 10:40 p.m. because you just don't know when the case comes in, and this have to be activated. So this is a 24/7 center that works around the clock. The next thing that we did, which also what we learned from SARS, was the need to screen and secure our campus. So if you see on the right-hand side, these are our thermal screening and scanning centers. So arising from SARS, where we knew that fever was a key feature, we have thermal scanners ready, so that this is a high throughput areas, and we have set it up at various key points of the hospital, and you can only enter at all these key points. And those who enter also had to be registered so that we can do easy contact tracing. And then they will be given a tag, as you can see on the left-hand corner, which corresponds to the day of the week. And if you have the right color, only then you'll be allowed entry into our wards and our hospital, as you can see from the right-hand corner. These are things that we have put in place since then, and is headed by our Director for Support Operations, who put all these things in place. Later, when you get the slides, you can also see their personal codes, their personal ideas about this. And as precautionary measures, we put in place visiting guidelines. So we started by allowing visitors, but as the situation, we recognize that the situation evolved as a number of cases, and we also recognize that different from SARS, where patients, where people could be actually infectious without being symptomatic, we recognize that temperature screening, while still useful, may not be catching all the cases. And with that, we needed to tighten our visitor guidelines too. So this is again where we evolved a bit, and it was different for COVID as per SARS because of the difference in the features of the virus. So in our general wards, no visitors, except for limited cases. So for example, those patients who have dementia and they need someone there that they are familiar with to manage them, we will allow a caregiver to be present, but this must be a designated caregiver and be protected appropriately so that he or she doesn't end up being infected or carrying the infection back into the community. And one key feature and one key difference in terms of the COVID experience versus the SARS experience was that SARS started out more as a nosocomial infection. It started from within the institution, the hospital, and then it spread outwards. But for COVID, it was more something that happened in the community, and therefore we put in a lot of effort to ensure that it didn't come into the hospital. And then we came out with disposition algorithms. If the patient has travel history, if they have symptoms, what do we do with the patient? What do we do with the visitors? And also safe distancing guidelines so that to decrease the crowding. We also identify, isolate, and test. This is our isolation ward. We have come up with standards. So one thing that we did was protocols, and constantly evolving. We have people that had to do the swabs, and we have to upgrade and ramp up our lab testing services. And we had to protect our staff. So we had PPE requirements for the different parts of the hospital, and this also kept evolving as we knew it. And we also tried to, we recognize that the safety of our staff is paramount. So we must do our best to minimize the risk to our staff, but at the same time, how do we optimize the use of the PPE? So we decided that while we have the PPE requirements, the team caring for the patient must be given the support. When we say that this is a suspect case, you may need certain types of PPE, but if you have a high index of suspicion that this may actually be a real case, we will allow you to wear a higher level PPE than what was in the protocol. So this is at the discretion, but the base, all of them must comply with. And so what we also try to do to optimize the use of PPE is, for example, minimizing exposure. So if you are examining the patient, maybe you can have only one doctor examining, so that only this doctor needs to be in the full PPE, but the rest will stand a bit back and they may not need the full PPE. And then to bundle as many tasks as possible, because if you come to do the plucking, you wear one set and then you take it out, you come back and take the blood, you come back and take it out, you come back and do a scan. So can we bundle as many things as possible so that you use one set of PPE for it? And also how we did optimize it to prevent wastage, and how do we store it and keep it safe. Staff movement and surveillance, we had travel prohibitions, we restricted cross-institutional movement, meaning that you can only work in one institution. We also, for staff that are at risk of exposure, we put them on leave of absence, which is over and above what their leave entitlement is. So it doesn't affect their leave entitlement, doesn't affect their pay. We also require them to monitor their temperature twice a day, and their HODs are supposed to monitor, and if there are symptoms of high medical leave or 3 cases, they have to alert us and we will then investigate. And we have our behind the scenes heroes, especially our housekeeping. So you'll see one is in a general area, and the staff who's doing the cleaning in this is our isolation room. When the patient leaves the area, we'll be doing it in the full PPE. So these are ensuring that the whole value chain is actually protected and secure as much as possible. And we tried to preserve the healthcare capacity, which was something that wasn't there for SARS, because SARS, everyone was in the acute hospital, but now because of the large volume of cases, and many of them are actually stable, and many of them at the recovery phase, they may still be positive for the virus, but otherwise they are recovering and they are very well. So they may not need the acute hospital services. So we free up the hospital services by decanting them to community, what we call community isolation facilities. We also deferred non-urgent cases where clinical appropriate. So our clinical staff will look through the case and then call up the patients and say that, okay, your case is, can we defer your case for 1 month or 2 months? And then we deliver the medications that they require to their homes free of charge. But within this, we also have opportunities amidst the adversity. So one of it was I think in many countries is the push for telehealth. we already have a telecare service for chronic disease management. And we also have a call line 24/7, which is more for social, to take care of our elderly who are staying alone. So these two services we found has been especially helpful, and we are actually ramping up these services. And what we had actually planned to do over the few years, we are now actually compressing it into a few months so that our patients still receive the care that they need, even though they are not coming to us, because we are deferring their appointments, so on and so forth. And they have a line to call in. And the other one is we also partnered with, one of the examples is with our airlines. As you know, with the travel prohibitions, many of the airlines are not flying, but they have well-trained staff who are good in care and service. So we welcome 70 of them who join us as patient care ambassadors. For many years, we have been talking about getting our nurses to work at the top of their license. So this is actually an opportunity for us to put it into practice, because with these colleagues joining us, we could, our nurses could focus on the more ill patients and the more complex patients, while our colleagues, our patient care ambassadors, could take care of the patients' more needs, other needs, like taking of the vital signs. But we train them, so you can see they're doing the mask fitting and learning the hand hygiene and so on. And we are very grateful that the society was very supportive of us. It came from all the top, from the Prime Minister, who dropped a note on Valentine's Day, so you can see the flower, to thank the healthcare providers, to an 8-year-old kid who dropped us a card, and another girl who gave it to us. And we also have a peer support program, as well as a staff counseling program, where staff who feel stressed or need support could come here. We also set up a respite center at our lounge, where anyone who needs to take a break, they can come there. And we were also very appreciative. This is a picture of a patient who recovered, who came back and gave us the flowers and donated some food to thank the staff who took care of the patient. So the journey continues. We are virtually doing rapid PDSA cycles, quality improvement on a daily basis, trying things. Some work, some don't work, and then we are moving on from there, but hopefully moving in the right direction and taking the opportunities as they arise. And I thought I would just end off with this last slide, that these are challenging times, but to keep us sane, it is laughter is the best medicine. And this is posters that we put up in our hospital by our patient experience group, where one is, you say, don't touch your mouth, eyes, and nose. And the other one, the Fantastic Four, is about the lift, so that there are only 4 people to have social distancing, so that you don't have the 5th person there, encouraging people to take the stairs. And during this period, while we fight the virus, we don't forget about the virtual virus too, because with the spam and the phishing, we need also our IT systems to be up. So those are the few areas, and I hope I leave you on that note with regards to the measures that we are trying to do. So over to you, Eric.
Thank you so much, Professor Lee. I think this was at the same time giving great overarching picture and a lot of very practical recommendations. While I'm waiting for questions to come in, there was an initial question I think that you addressed pretty well, but if you had any additional, was around, you know, the differences and the fact that you have very early recognized that this COVID was different than the SARS you had before, that the H1N1. And even though you could build on the experience, you had also to have the agility to respond to the specificity to this virus. You gave a number of differences. Is there any other one that you perhaps haven't mentioned that you would like to underscore of differences between this SARS and the previous ones?
Yeah, so there were 2 reference points actually that we had when we were coming out with our measures. The first was, as you mentioned, was SARS in 2003, but we also had the H1N1 pandemic, which was more like a flu virus which went around. So when it first came up, we were actually working through which part of the measures do we need to focus more on? And we took the approach that because it was still unknown, let's err on the side of caution. So we introduced the measures that are more SARS related. But as it went along, we recognized that the infectivity of this virus is actually higher than it happened, and the numbers are also different. So we had to adapt our measures, but at the same time recognizing that the mortality rate from the global data that we have for COVID-19 was higher than the H1N1. So we need additional precautions than for the H1N1. So these were some of the things that we had to do. But because of the numbers, we also introduced measures such as for the positive cases that are recovering, we could actually cohort them in a ward. So initially when the cases came in, the first few cases, we put all suspect and positive cases in single rooms so that to reduce the risk of cross-contamination and cross-infection, also community infections. But as we gain experience of it, we started to see that for those cases that are actually recovering, and they are on the journey of recovery, we could actually put them in a cohorted ward, because in Singapore, 60% of our wards are multi-bedded. So it's 5 to a cubicle or 6 to a cubicle, and we could actually put them in those cubicles. And then we kept our single rooms more for the cases that are more sick, as well as the suspected cases before we confirm. So for example, while we are waiting for the swab results to come back, we put them in the single room. And if we find that 2 swabs are negative, we could then actually move them out into a different general ward. So these are some of the differences that we put in place.
Okay, yeah, thank you very much. I think this is also very insightful. About the op center, which you really insisted on, I don't know if this one also was existing before, but it seems that it's a very important piece of the response. Was it also for the external communication? Because clearly for your presentation, the op center is the key switchboard, if I can say, for all the internal decision-making and communication. But is it also for the external communication?
For the external communication, we have a communications team that actually manages it. And for ease of work, it will go direct to the communications team, but at the same time, they keep the ops team informed. So while we require the ops team to be the central intelligence and the central node, we also don't want our ops center to be the bottleneck for the key issues. So for things like communications externally, as well as the general encouragement and those kind of things, it will actually be done by my communications team, which will keep our ops center informed. So so just to clarify, the directions that come from the ops center are basically directives as to what needs to be done by the staff in terms of the care protocols, in terms of the HR issues, for example, like the staff surveillance and all those kind of things. But the other aspects where we keep staff informed, where we encourage the staff, the morale and all those things, we have a communications team doing that. And the same in terms of liaising with the media.
Okay, yeah, thank you for this clarification. Around the staff, I have questions on whether you have provided to them bonuses or higher salary, the one who were facing, or even those that had to be restricted to work. Did you change anything in the salaries or the bonuses during this situation for the staff?
Okay. For us, because our staff are all salaried staff, that means we employ all categories of staff, whether doctors, nurses, allied health professionals, or the admin. So all of them are assured of their pay. But the question then is, so whether because there was some, I think in some areas it will be concerns that if I reduce the number of surgeries because they are elective, do they still get their pay? If I reduce the number of outpatient appointments, do the doctors still get their pay? The answer is yes. There's no impact on them. Then the next question is, do we pay them a higher salary? For that, I think we haven't come to this point yet, because we have a performance bonus scheme, which is actually adjusted on a year-by-year basis based on the performance. And this is certainly something that we will take into consideration. And the government has also announced that there will be a special bonus for frontline workers. And that was said in Parliament, and it was passed up at that point when it was announced, it was up to 1 month bonus. But to the credit of my staff, they have not actually asked about this. All of us are very focused on tackling the issues at hand, and that their current salaries are protected. But whether there's anything beyond that, they trust that we will actually work it out once the situation is better.
Yeah, thank you also for these clarifications. I have some questions around and concern around the idea of, the second wave of infections. Do you think that you have been able to already cope with it, or do you think that there is still a risk of a higher second wave? And in this case, what have you done? What could be still done? And what do you recommend to do?
Okay. I think I must preface my answer with the caveat that we are still learning. So whatever I say now, I think as things change, I think we have to adjust accordingly. So I would say that, in fact, Singapore has experienced a few waves. It's not just the second wave. The first wave was that of imported cases from overseas. And that seeded some community cases, which in a sense was our second wave, the cases arising from the community. And then we had a third wave, which was our own Singaporeans and residents returning from overseas when the infection started to spread around the world. So there was a spike in these cases. So for example, in one plane load of people that were coming back from some countries, the number of people that were positive was actually quite significant, and therefore they were put in the stay home notice, and we picked up a few cases from that. And from that, there were again a few local cases. And then now the wave that we are seeing is in the migrant workers in the dormitory, and we are seeing this actually rising. And this is the main challenge that we are tackling now. But the thing that we are seeing is with the circuit breaker, we are finding that the number of local community cases out in the community has actually, the weekly average has actually declined. So we are cautiously optimistic, but we are not fully satisfied with that yet, which is why I think 2 days ago, the government announced the extension of our circuit breaker by up to 1st of June, because what we saw was that there was still a significant number of what we call unlinked cases in the community, which one possibility could be there could be reservoirs of cases which we are not detecting yet, and we couldn't fully link the cases. And because of that, we felt that there was a need to extend the circuit breaker period to be able to, in a sense, flush out these cases before we can start thinking about loosening the measures. And of course, the other thing, which is the big unknown, is the travel restrictions. What will happen if we were to open it? So I must say, there are still quite a lot of unknowns in this, but we are cautiously monitoring the situation, responding as necessary.
Yeah, thank you. While you have upscaled the response for the COVID patient, you also indicated that you made a lot of efforts to reduce the flow, to postpone, some of the activity, to make it virtual as much as possible. Did you, while you were doing that, did you put at home some of the staff that was not mobilized by the COVID to reduce the risk of infection of your staff? That is one of your concerns. Or did they all come and still continue to work with relocation from the service where they used to be to COVID services?
Okay. So how we did it was we started by looking at essential services and essential work. So the first question that we need to say is, are you doing essential work? If you are doing essential work, then where can you do it from? Can you do it from home, or do you have to do it in the hospital? So if you are a doctor providing frontline services or a nurse, obviously yours is essential, but you have to do it in the hospital. It's very difficult to do that unless you are doing the telecare part. But some of the essential work could actually be done at home. And if it could be done at home, we will encourage them to do it from home. And when we do this, it is again not an all or none thing, because we could have some people that could be working from home for 3 days and then come in for the 2 days where they need to do something in the hospital. And then if that's for those that are classified under doing the essential services. But they could be, but because we are scaling down our services during this period, we have a group of services which we consider are non-essential. And for those that are non-essential, we would then look at it and say, can this staff be redeployed to other areas of need? So if this area of need, if they can be redeployed, then we will redeploy them. And then in their new roles, can it be done at home? Can it be done in the institution? And then we will decide accordingly. So the first question that we start with is this an essential service? If it's an essential service, you continue doing it. It can be at home. It could be in the institution. It could be your day job, or it could be a role in which you're deployed into. But if it's not an essential service, then you would be redeployed to some other areas of need. But you can again do this at home or in the institution.
And with all this strategy, did you got some of the staff infected? And if it's the case, you know, anyone who may be infected, that's he or she have special benefits in terms of labor or social benefits to once you are recognized as infected?
Yeah. Okay. To date, there were no staff that were actually infected at work. So we have a few healthcare workers that were actually infected, but their infection was actually in the community, or they were imported cases. So we had some healthcare professionals that actually went to attend, let's say, a conference overseas, and they came back, and a few days later, they developed symptoms. And that would be what we consider an imported case. Or there could be someone who was found to be positive, but when we trace it, it was linked to one of the existing clusters out in the community. So the thing is, within the work itself, at least within my hospital, no one has been infected while at work. And at the other part about the care, whether, regardless of where they were infected, patients who have COVID positive are provided free treatment. And this is something that the government has put in place to encourage cases to come forward to seek treatment rather than hiding in the community. So even for the cases that come for primary care, if you fulfill the case definition, then your swabs are also, in a sense, given free. Right? So the exception to this is that if you decide to travel, regardless of and disregard the travel advisories by the government, and you decide to travel, and if you come back and you get infected, then you would have to pay for your own fee. But if this something that you try your best, but somehow you got infected out in the community or elsewhere, your fees are covered.
Okay, yeah, this is very straightforward and encouraging very much a personal responsibility.
Yes.
We talk more and more, you know, about the whole issue, and you mentioned it, of the asymptomatic patients and asymptomatic transmission. You know, people, do you face that, and how are you going to deal with that, and especially if there is a potentially third wave? Or do you think it's by massive testing? Have you discussed about any strategies to deal with, because that's really a big difference with the previous epidemics, the whole issue
Yes.
about the asymptomatic patients and potential transmission. So what is the latest on that, and how do you see it forward?
Yeah. So in terms of the asymptomatic, I think the numbers are still being discussed in the scientific community as to what is the true extent of it. But for us, which is why we have highlighted the importance of the safe distancing to, whether you are symptomatic or asymptomatic, if you keep to a safe distance and you practice personal hygiene, and and you mask up, I think the risk of the transmission would be actually significantly reduced. So in Singapore, we have made it a requirement recently that if you are out of your home, you need to be masked. So even in office, you need to be masked. The reason why I'm not masked at the moment is because I'm alone in this room, so I do not need to be. But if you're with someone else in the same room, even though it is two persons, we are masked up. So so what we have done is, when you're at work in a clinical area, you follow our PPE guidelines, whether it is a surgical mask or an N95 mask. But in your own non-work setting, you can use a reusable mask, like a cloth mask or something. And in fact, the Singapore government has given one to everyone, which we can use, wash, and then reuse, because as a way to have complemented by the safe distancing. So these are some of the measures that we are putting in place. And we are also, in terms of the testing, we are also ramping up our testing. But our testing is done in a very strategic way, because it follows the public health principle that if you do a screening test, then it must be with an idea of an intervention in mind. So it is, in a sense, what we call a strategic test, that with an idea is, when we do the testing, is it to understand the prevalence in that particular area, such that we can then institute certain strategies, or is it for certain high risk? So for example, certain groups of staff that get potentially exposed, we do test them to reduce the risk even before they are symptomatic. So these are the several of the measures that we take. So it's I would summarize as is a mixture of various measures rather than one measure alone.
Yes. And you mentioned at a point, that you were, while doing a number of activities and putting in place processes, having a PDSA process where you really want to be on continuous improvement. Do you have any example of something that really gained from this continuous improvement cycle because it didn't work at first?
Okay, we have, but unfortunately at this current point in time, I can't think of an example, except we have some that worked. For example, our early decision to, in a sense, sacrifice our single rooms, because usually in Singapore, the single rooms are what we call for private patients. But we decided that here it is about the importance of tackling the disease. So very early in the stage, we decided that, okay, all single rooms will be given to suspected pneumonia cases or cases with acute respiratory infection at a higher rate. So we actually closed down 2 entire wards for it. And we actually, as we did it and we did our swabs, all those for this group, we were happy that actually this, we were able to detect the cases, and if we had done this differently and kept them in a multi-bed ward, then if we find that any of them were positive, we would have then to do a contact tracing and to lock down the whole cubicle with a few other patients involved. So this was something that we thought we needed to do. We did it quickly, and then we tested them. And when the results came back, we found that, yeah, the pickup rate was there, and we needed to, and it was the right decision to put them in the single room. So these are some of it that it was because we could, some people may say that we overreacted by putting them in here, and if we have swapped and found that actually everyone was negative, then it will be like, oh, okay, you have sacrificed all your rooms for these purposes. But it worked out. But honestly, when we went into it, it was more based on a precautionary measure, which in the end it turned out it was necessary.
Okay, thank you. Last question before summarize. It's around more or less the social acceptance. When, you know, public was public aware of locations where COVID plus with mild symptoms were managed at home, and how was that accepted? And like in some other countries, you know, nurses that are coming back home, you know, are people somehow afraid or reluctant that they might be COVID vectors? So what has been the social acceptance of taking cases at home, and as well as all those working against COVID when they are going back to their apartments and homes?
Yeah. Okay, just a little add clarification here. All the positive cases, once they are determined to be positive, they don't stay at home at the moment. They are actually either brought into a hospital or brought into an isolation facility. So they will not be managed at home until they are cleared of the virus. So that's the part. I know in some parts of the world, they do manage them at home, but in Singapore, at the current stage, we are not doing this, and we have taken them out. But for the positive cases, for each of the case, especially when at the earlier, we do say where they came from, and we also notice that the owners or the operators of the places where they stay actually do put up notices to say that we have one case in our estate. So while respecting the privacy, so like at the place where I stay, if there's someone positive in a block, in my block, there will be a notice to put there to say that we have been informed that someone staying in this block. They don't mention which unit, they don't mention the name, but they just say someone staying in this block was positive, and the family has been put on quarantine, and we have disinfected all the areas. And after the 14-day period, they will then put up a notice to say that, okay, we have we are happy to inform you that none of this. But all these were not by the government. This was actually individual places. So we also noticed some of the workplaces when they have a case and the person was at work, they also put up their own notices. Of course, initially there were some concerns, but after a few instances where we found that, okay, there was a case, so like in the place where I live, there were 2 cases, but after that, we saw that the precautions were all taken into place. Then with regards to the healthcare staff, yes, there were some initial concerns that, you know, we could be bringing the infection out into the community. So there was a lot of explaining and assurance that, for example, our staff who are managing what we call the hot ward and seeing the COVID positive patients, they wear the necessary protective equipment. They also wear the hospital issued scrubs, and they would discard the scrubs, and which will be laundered by the hospital. They will take a shower before they go home, even though they may go home in their uniform, but these are not the uniform that they wear when they are doing the work. So that was the assurance that we went out. And I think the community was also very helpful when I showed the pictures of the schools and the children and all those coming out to support. And initially there was some concern that the cab drivers were having concerns. So the Grab, which is one of equivalent to the Uber, they started a scheme called Grab Care, whereby their drivers could then volunteer to say that I am prepared. Of course, we pay the usual fee to pick healthcare workers when they need to travel. So, and they garnered quite a significant group. And this group will also, shared with them the infection control procedures and how they can protect themselves and so on and so forth. So I think over time, it has got, greater acceptance. And we are actually very encouraged by the support from the community in terms of it. And we are pretty appreciative of it.
Thank you very much. So we'll come to the end of our webinar. Just to give some high level or key messages. So please do not hesitate, Professor Lee, to complement if it's do not justice of this very rich and with multiple information webinar. So first one is the importance of multi-sector mobilization beyond the health sector to have a possibility to make sure that everybody in the whole society is really on board and bringing the contribution in their sector and all together is a meaningful because of that. The second one is the importance of agility. Although you have been prepared with previous infectious disease, whether it was the H1N1 or the SARS, the recognition of the fact that it is a different one and that you have to learn from the experience but build new responses is a very important element. The third one is also how it is important to involve early the primary care providers for massive screening and to make sure that the hospitals are not overwhelmed. The other one is the importance of the op center so that there is really a single source of information to make sure that, especially with such uncertainty, things are not derailing. Another one has been around the flow management, both in the facility with the visitors, but also including with the staff for limiting the traffic and making sure it's mainstream. Another one which has been a major problem all around the world is the use of PPE. For use, you have made a lot of effort to optimize and rationalize this use, even with reusing and making sure that you can bundle the activities. I think these are very interesting examples that can serve many hospitals. The way to deliver care, also you have participated in this optimization with telehealth, but with also mobilizing other partners. I think the mobilization of people from the flight attendants to bring I would say the comfort care to the people is a very, very interesting way also to make sure that you use better your skilled health workers. And last but not least is the importance to continuously build up and show the recognition from the community, from the executives to the staff to support a high spirit, because it's a long-lasting, during fight, and therefore the spirit is going to be one of the elements to overcome it. Anything I didn't cover, Professor Lee?
No, Eric, I think you're covering it better than me. Summarizing what I said in my long-winded manner, I covered it succinctly. So thank you very much. I just want to close and say that there's still a lot to learn from this, and we are constantly learning, unlearning, relearning as we go along, because some of our initial assumptions, like I said, is it like SARS? Is it like H1N1? Where does it sit on this spectrum, and how do we manage it? And also finding out new things, like for example, the asymptomatic spread, all those things. And we have to then calibrate our resources accordingly and our responses accordingly. So, we have still much to learn, and we look forward to learning from the rest of the international community as to how we can all work together to improve the care for our patients and to keep each other safe. Thank you.
Thank you very much, and I'll hand it over to Patricia for a few last remarks.
Thank you, Eric. Thank you very much, Professor Lee, and for to everyone who joined us today. Again, we will be posting the video recording of this webinar on our website, and you will be notified via email once it's available. We hope you can join us again. We still have some webinars signed up in the next few weeks, and the schedule is on your screen right now. You can register on our website. Just go to www.ihf-fih.org/webinars. Next Wednesday, we will have a webinar with Professor Shuti Chu, Dr. Chun Wen Cheng, and Professor Steve Wen-Ning Ng, who will discuss how Taiwan has strengthened its hospital infection control program through their experiences in the SARS outbreak and with the help of digital technology. So we hope you can join us there. Please keep safe and healthy, everyone. Together, we will overcome this global crisis. Thank you again for joining us today. Professor Lee, thank you very, very much for all the insights that you've shared with us today.
Thank you.
Thank you, and great greetings to all your staff for the great work they have been doing. Thank you so much.